Shin and Priyanka Shrestha had the inaugural pilot awards that were given last February of 2023. So they're wrapping up their work, and we were very glad that they were all available today to do this. So we are not going in any particular order. I said we'll just go in alphabetical order of last names. So Hyun Kim is going to present first, and her project was supported through the mentoring for the Center for Aging, Health, and the Humanities, right?
No. Oh, sorry.
Community engagement. Thank you.
Right.
And the title of her presentation is Exploring Disparities in Healthcare Utilization, Cancer Care Experience and Beliefs about Cancer Among Asian and Hispanic Patients Diagnosed with Cancer. So Hyun, please go ahead, and then we'll have a short question answer period after each presentation. Thank you very much.
All right. Thanks for the introduction and for this opportunity to talk about my project. I remember being excited when I heard about this pilot funding opportunity. I thought it would be beneficial to initiate my research and also to work with colleagues and students at GW, as I recently arrived at GW at the time. I know I only have 12 minutes for today, so I thought I might focus on a few specific aspects of the study and then move to the results that I found interesting. One specific aspect I want to address is that, as this title suggests, this exploratory study on disparities in healthcare utilization, cancer care experience, and beliefs about cancer among patients diagnosed with cancer ended up including Asians, Hispanics, and non-Hispanic whites as reference groups. The reason was related to the study design secondary data analysis using the HINTS-SEER data. For those of you who are not familiar with the HINTS, HINTS is a nationally representative survey with these contents that has been administered by the National Cancer Institute every few years since 2003. For this project, I used the HINTS-SEER dataset, which is a pilot study to oversample cancer survivors of the HINTS original study. And then they used specific cancer registries from surveillance, epidemiology, and the results, the SEER, and those registries listed here. And because of the geographical characteristics of these registries, this data from the HINTS-SEER had lower representation of Black populations. And this data is one of the restricted data sets, and I thought it might be beneficial to use my study to characterize disparities in healthcare utilization, cancer care experiences, and beliefs about cancer among diverse cancer survivors in the US. I'd like to briefly introduce the main study variables. As I mentioned in the title, I have three main study-dependent variables. Healthcare utilization was assessed with three items, asking having a particular nurse, doctor, or health professionals as their primary care provider, and number of visits of healthcare professionals within the last 12 months. And this question was asked with the categories from 0 to more than 10 times, and receiving any treatment for cancer. And cancer care experience was measured using a bunch of questionnaires, self-rated quality of care and healthcare communication quality, and cancer care issues experienced was included. And those experiences was including specific conditions such as cognitive impairment, neuropathy, severe fatigue, and nausea, like symptoms while their treatment, and financial burden that they experience caused by cancer or its treatment, and any experiences with care-related issues such as bringing test results to the appointment, waiting for results, and redoing tests, etc. And finally, beliefs about cancer, I used 4 items from the data set, and one of them was about level of worry about cancer recurrence. And the other 3 items were about the degree on agreement with statements on cancer causation and prevention. And I used a composite score for fatalistic cancer beliefs, higher value as higher fatalistic cancer beliefs. And here is the analysis procedure. First of all, I did the descriptives of the study variables. And for those means and proportions of each outcome variable was estimated by race ethnicity to see any differences across those groups. And I found one of the 3 main outcomes, which is the cancer care experience. I found no significant difference across the race ethnic groups. Most of the participants rated high level of self-care quality, self-rated care quality, and communication quality across all the ethnic groups, which is very positive outcome. But I found some differences in fatalistic cancer belief and healthcare utilization, which led further analysis using multivariable logistic or linear regression based on the level of measurement of the outcome variable. And those models included these covariates listed here. And I used the weighted analysis using Stata for this project. And in total, the data set has 1,234 respondents. And as you can see here, Blacks and others had really small proportion. So these groups were excluded for this analysis. And most of them were elderly. Mean age was 70 years old with quite large age variation. And most common cancer was breast cancer, followed by prostate cancer, non-melanoma skin cancer, melanoma, and lymphoma following. And according to the Hint-Sear methodology paper, individuals diagnosed with only non-melanoma skin cancer was excluded. So these individuals were diagnosed with multiple types of cancer, which in total about 29% of the total respondents. And the language used in this study was English, so all the respondents used English. And in terms of the health insurance, most of the respondents say yes to if they had any types of insurance. So for this variable, I didn't find quite variability to be included as my covariates. But one of my team members raised questions about health insurance, which I agreed with since our research topic is related healthcare utilization. So I looked into further items related health insurance from the data set, and I found these variables and did some analysis across the racial ethnic groups. And interestingly, this item, if they purchased insurance directly, had some significant differences across these groups. So about 32% of non-Hispanic whites purchased the insurance directly, whereas 16% of Hispanics and 13% of Asians purchased directly. So with these significant difference across this group, I included this purchase directly health insurance variable into my final model, which I will present over the next 3 slides. And here is the first model for having a regular healthcare provider, which is one of the healthcare utilization outcome. And please be noted that this outcome was coded as 1 equals no, which means odds ratio larger than 1 indicates higher chance of not having a regular healthcare provider. So Asians had higher likelihood of not having a regular healthcare provider compared to non-Hispanic whites. And several covariates showed significant results. So for example, education, higher education was associated with lower chance of not having a regular healthcare provider. And currently not working full-time was associated with higher chance of not having a regular healthcare provider compared to those working full-time. And interestingly, purchased directly, their health insurance was associated with a lower chance of not having a regular healthcare provider, which I think makes sense. And this is the second outcome, which is about frequency of healthcare provider visits. And again, this was coded as 1 equals none. So Asians had a higher chance of not visiting healthcare provider within the last 12 months compared to non-Hispanic whites. Again, lower healthcare utilization among Asian Americans, which is one of our main findings of this study. And education also was associated with this outcome variable. So higher education level was associated with a lower chance of not visiting healthcare provider. And interestingly, females showed higher chance of not visiting healthcare provider compared to males from this result. And lastly, fatalistic cancer belief, neither Hispanic or Asian showed significant differences between compared to non-Hispanic whites. But with those covariates included in the model, but age and education was significantly associated with fatalistic cancer belief. So older age group was associated with lower level of fatalistic cancer belief, I think, which is somehow interesting. And higher education level is associated with lower level of fatalistic cancer belief. So here is the main findings and some thoughts about implications. We found Asians underutilize healthcare compared to non-Hispanic whites. So I think there is a need for increased attention for this ethnic group's healthcare needs, and further studies to understand any barriers or cultural background or their preference in their healthcare utilization should be studied. And education influenced both healthcare utilization and cancer beliefs in our study. So educational background as a social determinant of health should be considered in healthcare research and policy-making decisions. And fatalistic cancer belief declined with education. So culturally appropriate education on cancer causation, prevention, and treatment for Asians and Hispanics are needed. And direct health insurance purchase correlates with regular healthcare access. And those rates were lower among Asians and Hispanics. So information on options for choosing health insurance for these groups would be beneficial. And lastly, I'd like to acknowledge my research team. Thanks to Kathleen, Adriana, Daisy for their shared interest and input for this project. And Vanessa is a PhD student whom I collaborated with this project and continue to work for another project. And this was funded by Center for Health Policy and Media Engagement. And I would like to thank Dr. Rick for his strong support from the very beginning phase of this study. So this is what I prepared for today, and I'm happy to receive any questions or comments. Thank you for your attention.
Thank you so much, Hyun. Very interesting findings. I'm sure you're going to have a lot of questions. I'm wondering if Rick would just like to say a few words before we open up to questions, just the relevance to the Center for Health Policy Goals.
Thanks, Kathleen. Can you hear me okay? Okay, good. Well, first of all, I'd like to thank Hyun for doing such a remarkably strong job with the funding that she received. And as she mentioned, I had the wonderful opportunity to meet with her before she started her project and talk to her a lot about the policy implications, which we will continue to talk about. So I hope that what you see from Hyun and the work that she's done will spark some interest in all of us to continue to think about these annual intramural funding. Now I'm being very hopeful that they will be annual and from the centers. And I offer, like I did with Hyun, I would like to offer my services and my network of connections in the policy world to individuals who are thinking about submitting or interested in submitting for the intramural grants. I'm more than happy to help. And obviously the idea of primary care is a big focus in the center, and looking at some of her results around these data relative to primary care and demographics around primary care. One thing that struck me, and I'll kick off the scholarly part, Kathleen, one thing that struck me was something contrary to everything I've learned in primary care, was that the males utilized the healthcare system more than the women did. And that's contrary to what I've seen in large utilization data sets, and very interesting finding. And I'd be curious to dig deeper into that to understand that. Hyun, any comments on that?
Oh, yeah, I think I was kind of amazed with this outcome too. But because these sample characteristics like elderly and cancer survivors, they might influence these findings. Yeah, but that's what kind of I thought so far. So any additional comments or thoughts would be appreciated.
Yeah, I mean, the other interesting finding there is typically when you're looking at this population, that's, as you mentioned, the older you are, the higher at risk you are for cancer and more likely you are to be a cancer survivor. Generally, in general, the population of the aging, of the elders is more dominated by women too. So the idea that there's more women in the general population, and our current thinking and what the data that I've seen is that it's harder to get men in, particularly for primary care, perhaps not as much in specialty care around cancer care. That would be the interesting perspective here. But I know in primary care, I've done a number of studies where I've used wives or partners of men to get men in for preventative health care, because women typically have a better track record of coming in for preventative health care than men do. But that's like you said, it's a different population than this particular population. I'm going to stop there, Kathleen, because I don't want to hog all the time.
Thanks so much for your comments and also your thought-provoking question. And before I ask for other questions just related to that, what I'm wondering is, if I remember correctly, 2 of the other big cancers are not included in this data set, lung cancer and colorectal cancer. So we've got prostate, which is a male-specific cancer, breast cancer, which is predominantly in women. So not that should factor in when in the multivariate models, but just the population that was sampled are just related to people who had these particular diagnoses. So I'm just wondering if that is maybe factoring into that surprising finding with women being less likely to seek care.
Yeah, I think, yeah, that's a good point. And although there was respondents who was diagnosed with lung cancer and liver cancer, but the incidence rate was very low, so I didn't include that one here. And we had kind of half of males and females in our population in this data set. So, yeah.
Any other questions for Hyun?
Kathleen, I'm trying to find my hand to raise, so I apologize. I can't find it. This is really fascinating. It would be interesting to understand whether or not these cancer survivors were not really informed and encouraged by the specialists and providers to continue to follow up from a prevention point of view. You know, you would think, having gone through such a traumatic experience, that they would have that prevention wellness follow-up. Did you get any sense of that?
As this population is already diagnosed with cancer, so I was not able to see the kind of continuum, but these people is already get into some kind of healthcare, especially for the non-Hispanic white population. But within this population, I found Asians had lower rates of having a regular healthcare provider and having regular healthcare visits during the last 12 months compared to non-Hispanic whites. So I see some possibility of discontinue of care for those Asian groups, particularly based on this analysis. So I think these results encouraged me to focus on Asian Americans, which I am interested in my research, and to further study their health behaviors and any barriers, for utilizing this primary care and having a regular healthcare provider and these kind of things.
Interesting.
Thank you.
All right, thanks for your question too, Esther. Okay, thank you so much, Dr. Kim. We're going to move to our next presenter, Dr. Shin, whose presentation is, it's right here, Staffing Ownership and Other Factors Associated with Nursing Home Quality of Care. And Dr. Shin is, project was funded in alignment with the Center for Aging, Health, and the Humanities. So thank you very much for presenting today.
Thank you for your introduction, and then thank you very much for the this great opportunity, because this topic is really hard topic to get funded, and especially as a new faculty here like Dr. Kim, it was great resource for me to continue my own research area. Okay, as you may know that the quality of nursing home care has been considered a major problem in the United States. About 1/3 of residents had adverse events that could be prevented, and many residents are suffer from like falls, pressure ulcers, weight loss, rehospitalization, and deaths with low nurse staffing. And especially during the COVID-19 pandemic, about 2 million nursing home residents had infections, and 172,000 people had died because of the COVID-19. And between 2013 and 2019, like more than 75% 75 to 82% had been cited for one or more deficiencies with infection prevention or control. Okay, so what is known about this topic? In the United States, about 70% of nursing homes are for-profit, and for-profit ownership was associated with poor quality or higher deficiency compared to non-profit or government facilities, because they have very low level of the nurse staffing. And the bigger size, larger nursing homes, and then higher occupancy, the larger nursing homes had higher deficiency scores, and then higher occupancy rates in nursing homes, also with lower deficiency in one study. And the nursing homes with more Medicaid residents have been found to have lower quality. Usually nursing homes are financed through the Medicare or Medicaid, but nursing homes prefer to have Medicare residents for better profits for short-term post-acute care than poor residents require long-term care. And this study used 2019 robust data set to examine the Center for Medicare and Medicaid to calculate deficiency scores. Unlike previous studies that often focus solely on the deficiency counts for a single year, these data provide weight score to consider scope and the severity of the violation. Also, this study used the CMS payroll-based journal data, staffing data, which were required starting in 2017. So PBJ data compared with the OSCAR data, online survey certification reporting data, PBJ data considered more accurate and comprehensive than the previous reliance on 2-week self-reported data. at the time of the annual nursing home surveys. So we used the PBJ data, not the Oscar, and then we used the 2019 data because during the COVID-19, the healthcare survey was not done, and then we had 30% of the missing data. So the purpose of this study was to examine selected factors related to CMS developed deficiency scores for nursing homes in the United States. So higher nursing staffing, like nurses, LPN, CNA levels will be associated with lower deficiencies, and ownership, nursing home size, and occupancy rate and percentage of residents paid for by Medicaid will be associated with some deficiencies. Okay, the population of this study were all Medicare and Medicaid certified nursing homes in the United States during the 2019 fiscal year. This is secondary data also analysis using CMS payer and PBJ and CMS provider data and their long-term care focus data provided by the Brown University School of Public Health. Okay, so this figure shows the matching procedure for the 3 data files used in the study. The primary data file was the CMS provider data set, had 15,050 nursing homes with separate Medicare, Medicaid provider IDs for 2019. Although we exclude 856 nursing homes without data values. The CMS cleaning procedure eliminated PBJ records, payroll-based records that were incomplete or if they have some error data. And we linked quarterly PBJ data, the staffing data, and create staffing average for the year, and which were linked to the provider the file. And the last step was to link this data set from the long-term care focus with the provider files, and another 159 nursing home data did not have data values, so we eliminate it. So the final study population was 13,310 nursing home data. Okay, so definitely the dependent variables, we use the deficiency scores or the dependent variables in this study. The CMS calculates the health inspection score based on points assigned to deficiency for each nursing home's 3 most recent recertification health inspection, and as well as on the deficiency from the most recent 3 years of the complaint inspection. And points are assigned to the individual deficiency according to their scope and severity. And more serious widespread deficiencies receive more points, with additional points assigned for the substandard quality of care. And additional points are added for the 2nd, 3rd, 4th revisit. And the CMS calculates a total weight health inspection scores for each nursing home, with a higher weighting for the most recent regular and complaint surveys and lower weighting for the 2 previous surveys. And then definitely the nurse staffing is one of the independent variable. The Medicare, Medicaid certified nursing home should submit detailed information 4 times a year based to the CMS. And then which manages these data and offers them freely to the public. So you can have a nursing home information from like a nursing home compare website. And we use the hours per resident day as a variable, which means the average hours worked by nurses, LPNs, and CNS divided by a total number of residents per day. And also, I include like ownership, for profit, not for profit, or government, and size, total number of beds, and occupancy rates, and residents paid by Medicaid as the independent variables. And the resident case mix was included in this model as a control variable because the higher residence acuity requires more nurse staffing resources. The Medicare and many state Medicaid programs pay higher rates to nursing homes that have higher acuity to address the need for higher staffing. And over the years, CMS adopted different acuity measures sometimes it's quite vague. So we use the long-term care focus data average resident acuity index for each facility, which is very concrete. Include residents' ADLs and nursing care needs such as suctioning, IV therapy, tracheostomy care, or other care needs. Okay, these are three data resources. Okay, and then using the OLS with the fixed effects model controlling for state variation, and then the AI technique to shop the random forest was used like a machine learning method. Okay, this is the descriptive statistics for deficient scores and nursing home characteristics. The average hours per each nurse staffing, like nurses RN, was 0.53. Which means about 30 minutes, 31.8 minutes, 32 minutes. And for profit nursing homes, it was 0.44, which is about 26.4 minutes. And for not-for-profit nursing homes, which was 0.69 HPRD, which is 41.4 minutes. It's quite some variation here. And then average occupancy rate was 75%, and average number of beds was about 107, and 72% were the for-profit. And the percentage of residents covered by Medicaid was divided into quartiles, with the highest group set as 76.2% or higher. Okay, so this is major findings of this study. As nurses, hours per resident increased by 15 minutes, the deficiency score decreased by 3.17 scores. And then higher LPNs and CNA hours also were associated with lower deficiency. And the bigger size, larger facility size, and highest percentage of residents by Medicaid were associated with higher deficiency. And also higher occupancy rates were associated with lower deficiency scores. So this is the table about the major findings. And then this is the random forest shape plot of factors related to deficiency scores. And x-axis here represent degree of impact on the dependent variable. The y-axis represent independent variable, which were sorted by overall impact on the dependent variable. Each point in the graph corresponds a nursing home, and each color represents the independent variable's value. The order of the y-axis refers to the degree of the effect on the dependent variable. So here, the ownership was the strongest organizational factor, both X and Y. The red color corresponds to a for-profit nursing home, and the blue ones refer to not-for-profit and government nursing homes. The blue points were spread, whereas the red points were not spread. And nursing home deficiency scores decreased for not-for-profit and government nursing homes. On the other hand, most for-profit nursing homes, red points, showed increased deficiency scores. And higher occupancy rates were associated with lower deficiency score. Most dots on the right-hand side were blue, whereas most dots on the left-hand side were red. The blue dots correspond to nursing homes with low occupancy rates, which means nursing homes with low occupancy rates were likely to observe more higher deficiency scores. And nursing homes with more Medicaid residents had increased deficiency scores, where most dots were located on the right with red colors. And the RN HPRD plus were red on the negative values, which means lower deficiency scores, showing more RN HPRD was associated with lower deficiency scores. So this is my conclusion based on this study result. The for-profit owners and other provider characteristics are also strongly associated with nursing home quality, and definitely nurses and other nurse staffing hours were associated with the higher nursing home quality, and findings support the important role of the quality nurse staffing. And policy implication is that last year, the CMS released the proposed new nursing home minimum staffing standards, which is very disappointing because over 20 years, the experts and CMS study found that each nursing home required at least 4.1 hours of direct care. But last year, they lessened to the only 3 hours of direct care per resident day. So the consumer advocates are concerned that proposed minimums are too low, and the nursing experts have recommended higher standards that are tied to residents' case mix levels. And so I think this kind of study should be repetitively conducted in the future, but it's very hard topic to get funded. So I really appreciate the funding from the Center for Aging and Humanities, and then help of the administrative help from the director of Dr. Melissa Betcher. And then this study was supervised by my mentor, research mentor, Dr. Charlene Harrington, the UCSF, the retired professor. And then I feel like I do my PhD degree again, because when I do my PhD, I used only the Iowa State data, and this time I used the data for the across the United States. So it was very challenging, but it was very meaningful, and then I'm so glad this project was done. And thank you very much. And then please give me your precious comments or questions. Thank you.
Thank you so much, Ju.
Thank
Melissa, just comment as the Center Director for Aging Healthy Humanities before we open it up.
Yeah, this is a really important topic at, obviously a national level, and there's been a lot of resistance. It's been, staffing issues have been part of the national conversation for at least 30 years. And so I like how she tied her work into the policy impact that this could have. I did have one question about your acuity index, the slide that had all the little variables in it.
Yeah.
Right there. And you have you included independent residents and independent eating. So I just wondered why, if residents are independent, you would think that wouldn't require staffing support or staffing hours. So I just didn't know why you had included those.
Oh,
If
okay,
you're
so
independent with your ADLs compared to.
Okay, so toileting independent residents here.
Right, because theoretically the resident should be able to go to the bathroom, but you
independent.
Yeah, because the ADLs are the major driver of stuff in addition to the skilled nursing piece. But for nursing assistants, so anyways, and we can talk about that offline. I just didn't know.
Oh, yeah. Actually, I don't know the answer at this point, because I just used that acuity index because I thought because they developed this formula, but I will ask them why they. I think that's very important point to figure out why they included.
Yeah. So this acuity index it existed, or?
Oh, I think they wait because they multiple by toileting dependent residents multiple by five times.
Oh, okay, I see. So they're weighted in some way.
Yeah, that's my understanding, but I will double check about that one.
Okay. All right. Now I understand the rest of the formula. So
yeah.
Otherwise, great work. Very excited.
Thank you.
Thank you, Melissa. In the interest of time, we're just going to take one question for this presentation. If anybody has a question for Dr. Shin.
Kathleen, it's more a comment than a question that might be potential future funding for continued research on this. As you may know, 6 days ago, CMS came out with new significant requirements for accrediting organizations, really lifting the bar on what they must demonstrate that they do as part of accrediting a long-term care facility or a nursing home. So it would be interesting to have this research continue. to see whether or not, as a result of that significant impact to the AOs, there is an increase in these quality outcomes for
Mhm.
residents. So I just wanted to put that out there. And I can provide you the link if you're not familiar with it.
I'd
Yes,
like-
please.
So, yeah,
Thank
and-
you. Thank you very much.
Yeah, that's very, very interesting. Thank you for sharing that. And just a comment I wanted to make, well, I guess it's kind of a question is, when you think about RN staffing in long-term care, you know, I, as someone who's not familiar with that area professionally, does that actually mean hands on the patient, or is it reviewing medications and calling the, geriatrician, or, is it direct supervision of staff, which, seems to be an issue nationwide? I was just curious about what RN staffing actually means in this context.
It would be great to define it, because right now nursing homes are required to have one RN in the building for 8 hours a day, but one has to be on call for 24. And, they put their administrative staff in this mix compared to like who's actually on the floor providing the direct care is typically an LP and a nursing assistant. So the whole thing is a little skewed and wonky.
Yeah, a
And-
little convoluted at this level. Yes, you really have to.
Mhm.
Thank you. Well, thank you very much for this presentation, Ju. It's very really a
Thank
lot to think about with yours as well.
Yeah. Thank you very much for your support.
And then finally, we have Dr. Shrestha. Priyanka Shrestha is going to be presenting hers. Unlocking the Hidden Heroes, Empowering Family Care Partners to Optimize Delirium Care for Persons Living with Dementia. And her study was funded through Center for Aging Health and the Humanities. And I did see her. Oh, there it is, popping up.
Hello everyone. Okay, let me see. Let me try and share my presentation here. Are you guys able to view my presentation?
Yes.
Okay, great. I'm just using a new app. So yeah, hello everyone. I'm Priyanka Shrestha, assistant professor at the School of Nursing. And I'd like to start with thanking Melissa Batchelor, the Center of Aging Health and Humanities, for giving me the opportunity to do this research. And it was really helpful as starting out as an assistant professor to kind of start developing my research idea so that I could apply for some external funding. I'd also like to thank Kathleen as well, because she really extensively helped me when I was working on my pilot project application. So the title of my presentation is Unlocking the Hidden Heroes. So empowering family care partners to optimize delirium care for persons living with dementia. About a basic introduction, delirium is a clinical syndrome. It is characterized by alteration of attention, consciousness, and cognition, which reduces the older adult's ability to focus, sustain, or shift attention. It develops over a short period of time and fluctuates during the day. So delirium, when happens in older adults with dementia, is called as delirium superimposed on dementia, which is very common, distressing, and associated with poor outcomes, not only on the older adults, but also for the family care partners. Less than 50% of all delirium cases are detected in routine care, with DSD often misattributed to worsening dementia due to healthcare professionals' limited awareness of the patient's baseline cognitive function. So a lot of times what we see practically is that DSD often occurs or starts in the home and results in hospitalizations or ER admissions, and DSD that is undetected at home is a missed opportunity to intervene. So given the DSD prevalence and projected growth of dementia globally from 55 million in 2021 to 78 million in 2023, DSD's impact will likely increase. So based on prior research, we know that family care partners are ideally situated to observe and report on the baseline cognitive abilities and subsequent alterations in individuals with DSD. Yet the specific type of support that family care partners require and prefer to effectively identify and manage DSD at home and mitigate the related caregiving distress remain uncertain. That's why the purpose of this research study was to explore the family care partners' common support needs, preferences, and priority areas in caregiving for persons with DSD to inform future intervention development to support family care partners. So talking about the methodology, I used a qualitative descriptive method. We used a broad purposive and snowball sampling. We conducted around 12 interviews. The setting was variable, and we recruited participants from an integrated memory care clinic in Emory, Dementia Action Alliance, Grand Oaks Assisted Living Community in Virginia. So the measures used were semi-structured interviews and demographic questionnaire. I know I started with thinking of doing a focus group discussion, but then later I changed my measures to do semi-structured interviews. So talking about the findings, so there were two major themes that developed during the analysis, and on the left are the sub-themes. So one of the major theme was family care partners' roles in the DSD management. So one of the major sub-theme was the ensuring safety and comfort of care recipient in challenging times. So when the older adult develops delirium and has confusion, a lot of times they become aggressive, and family care partners were really there to calm them down and to ensure they are safe, not only for the older adult themselves, but also for other family members who might be living in the same home or in the community. And the other sub-theme was nurturing well-being of care recipient with family joys. It was observed that a lot of times family care partners use some familiar objects. So for example, one of the caregiver's mom, she loved watching puppies in the garden. So what she did was she got her a puppy and used to take her out in the garden and sit, and that really helped with the confusion and making the older adult care recipient feeling refreshed. Other sub-theme is incorporating consistent into daily care. Family care partners really notice that even though it's just activities of daily living like dressing, eating food, or bathing and all of that, it was important to develop a consistent routine. So for example, a person eats a breakfast always at 8 a.m. or 9 a.m. or for somebody it might be 7 a.m. It was important, even if the older adult would not want it, the family care partners developed a consistent routine to make sure there was not confusion among the older adult patients with DSD. And the other important role is of the providing empathetic and reassuring presence of family care partners. So a lot of times other research, other literature has also talked about the importance of reassuring presence and providing comfort to older adults who develop confusion during delirium. So family caregivers, the family care partners talked about how they establish physical contact, hold their hand, talk face-to-face, be in their eye level, and make just reassuring the older adult to say that they are fine and everything is going to be okay. And the family care partners observed that it really helped during the times of confusion and to manage the confusion when the older adult was like really frantic and being combative. So other important major theme was support needs of family care partners to optimize DSD care. So this was one of the major themes or purpose of my research study, to understand what the support needs of family care partners really are and what can we really do for them to effectively manage DSD. So some of the sub-themes that keeps coming up in the literature is about DSD awareness and how there's a variability among how family care partners do not know much about delirium or DSD and how to manage it, and they want some practical advice as well. And a lot of family care partners, interestingly, a lot of family care partners in my study were very young. So they were really looking forward to some kind of workshop or webinar or some kind of online session that could tell them about the symptoms of delirium and DSD, how that is different, what they can do, how they can communicate with the older adults, and how to manage it, and at what point they will have to report it to the healthcare provider. So that kind of knowledge is what they were looking for. So since they were younger participants, they wanted more online version of the education, but based on my previous experience in my dissertation research, the more caregivers who are at the, like sometimes the spouses who are like older adults themselves who are a family care partner, they would appreciate more like informational brochures, something that they could hold in hand and read. The second sub-theme was improving care through family engagement, prioritizing care recipient baseline and preference. I really like this quote and I'll just read it. So I think the biggest thing from the hospital was wanting a doctor or even the charge nurse, something to be like, hey, what was this guy like before? Because we weren't there in the hospital with him. So that's the father who was admitted to the emergency department. So ask us, the people who saw him every day, and what was he like? Is this normal? How off normal is this? How not normal is this? So family care partners really want the healthcare professionals to ask the family, to ask how the older adult who is hospitalized, how they were normally, and whatever the symptoms they are presenting, how different is it from the normal setting, so that they could form a baseline and provide information accordingly and provide treatment accordingly. The other important sub-theme was prioritizing family care partners, which is addressing social functioning, mental well-being, and respite care needs. Family care partners, a lot of them express that they, as a family care partner, they provide intensive caregiving and are at home all the times with the older adults. So they wanted some kind of support group where they could share their experiences. They would want it either online or in person as well, because a lot of times family care partners feel isolated and they want someone to just hang out with and to share their experiences. And the other part was also engaging the older adult with delirium or DSD, because before the confusion, they were very much active. Before the dementia, they were also very much active in the society with friends and relatives. But then after the condition, they were less active. So they also want, the family caregivers want to also engage the older adult in some kind of activity to maintain their cognitive functioning. And the other sub-theme is utilizing technology to overcome communication challenges with care recipients. A lot of times when dementia occurs, and especially during the times of confusion, the older adults are not able to form words. They are not able to communicate about what their need is, what is wrong with them. So family care partners really want some kind of technological advancement that would help with the communication. So one of the family care partner talked about how he used some kind of generic app that would have like pictures of water or like a call bell or something, and then he could just press that in the iPad and it would say water, or would like ring a bell to call the family care provider. So I think something like that for younger family care partners would be really nice, and that would really help to kind of improve the communication with the older adult and the family care partner. And finally, the last sub-theme is the fostering compassionate communication with healthcare professionals and family care partner. So family care partners really, when they get some encouragement from other family members or when from healthcare professionals, it really boosts their morale. So one of the family care partners said that just their words of encouragement, which really helped give me a boost and boost my morale, that can be there for her. I can do this, that I shouldn't give up. So that kind of morale boost would be really nice for family caregivers. That way they will feel supported. And the other part was, so one of the family care partner talked about how like nurses were like very professional when they come in to see the older adult patient. So if they come in a more welcoming way and be more warm towards the older adult patient, as well as the presence of family care partners, they would feel more supported. So I'll just go to the implications. So some of the major findings that I'll discuss here and the implications for future research is, as I said, the participants' knowledge about delirium showed considerable
Priyanka? Sorry to interrupt. Could you just wrap up in a minute or so? So we've got just a couple minutes to discuss. Thank you.
Okay. So distributing some easy to understand information pamphlets for some older family care partners, as well as creating some online webinars or support about education about DST that emphasizes prevention, early recognition, management, as well as that outlines some evidence-based non-pharmacological interventions would really support family care partners. So family care partners also really appreciate the presence of support groups, but then support groups should also conduct some thorough assessment about the needs and preferences of the members so that the discussions of the support group would be around the prevention and the needs of the family care partners. And the other part is that participants noted that the effective management of DST in patients relies on strong support from family and clinician involvement, but oftentimes that support is lacking. So future research should also focus on the support network and support-seeking behaviors of family care partners to assess the preparedness and preference for extent of involvement in caregiving. Thank you.
Wonderful. Thank you so much. And I love the contrast of your project with the other two, because we really have, you know, a very important area of inquiry where there's not a lot known, and then we have population-based work that's been done. So just to show you guys, you can do a lot with a small pilot grant when we have future calls. Melissa, would you like to just say a few words before we entertain a few questions for Priyanka?
Yeah, no, I mean, I think this was a really interesting project, and particularly, you know, Priyanka and I met about the types of questions she was asking, because you can't, we talk about delirium superimposed on dementia as though all should know what that is. And it was like, you can't ask a family member, because you're, you know, it'd be like me asking my mom, you know, I think that, you know, do you think that Nani has delirium superimposed on her dementia? She'd be like, what? No. But if I said, has she been confused, or does she have a bladder infection that made her more confused? That's how a family member is going to recognize that. So I think that's the type of education that as providers we need to be aware of. And I think that's one of the biggest things I learned from her project.
Thank you, Melissa. Any questions for Priyanka in our last few minutes together, or comments? Well, I always have one up my sleeve just in case. So, Priyanka, I'm really interested in how you're going to use this information, which is very rich, to take your next step in terms of developing a proposal or manuscript or whatever you have in mind.
Thank you, Kathleen, for the question. So I've submitted this, the findings of this study as an abstract for American Delirium Association conference. I'm also working on this manuscript as well, but for the next steps, based on the findings from this study and then a little bit of findings from my dissertation, now I think I'm ready for the next step, which is the intervention creation for family care partners. So that will be my next step, and application for some kind of funding to develop that intervention. And that intervention, in my mind right now, it would look like education about delirium, DST symptoms, what they could do, management, prevention, and all of that. But then also some other parts, since the communication challenge was an important aspect, training family caregivers about compassionate, emotion-focused care based on the gestures, movements, how they can understand what the older adult is really going through, and as well as incorporating some kind of technological advancement, maybe creating some kind of app to help with that communication challenge, because that was what really came up in my study.
Yeah, it sounds very resonant of your findings. So thank you very much. Right, so, well, we're right at 1 o'clock. Thank you so much for your attention. I know there was a lot of data packed into this 1 hour. To all three of our presenters, thank you so much for doing so much work with the pilot monies, and I'm glad that you've found findings that are going to be useful to you in the future. Congratulations.
Thank you.
Thank you very
Okay.
much.
And
Thank you.